I'm here from Glasgow, down to speak to you tonight. The previous speaker, astonishingly a German with a sense of humour, made a comment about non-native speakers. And I'd like to say to any non-native speakers, yes, this is English, and you'll just have to put up with it for the next 45 minutes or so. Yeah, laugh, not 45 minutes, you're fine, I'll whiz through this. I want to talk about the new drugs. New anti-epileptic drugs have been a marked feature of the last few decades. And this timeline shows some various events over the last 30 years since the new drugs have begun to come on stream. And what this tries to show when you look at the molecular structures on the way down is really the advance that we've got there. And the thing is that by 2009, as we heard earlier on, we already have more drugs on stream ready to come on the market than we've had really at any point over the last 15 years. We've got a very vibrant research programme in pharmaceutical industry keen to provide us with these new treatments. And actually, what does this mean for us in the clinic? And what I hope to maybe touch on later on is exactly what it means, the challenges that it lays down for the needs for our research in coming years. You'll see some of the events there. I can't see the wee pointer here. Is there a pointer on this? Oh, there's this pointer here. You'll see some of these events on the way down. Do you really trust someone to look after you when they can't work a simple pen torch? But you can see some of these things. We've got the motor car and the space shuttle and this here. Now, some of you will think this is to do with England World Cup win, but it's not really. This is when Celtic won the European Cup in 1966. But actually, now you mention it, it might be England winning the World Cup because you'll see the ball hasn't crossed the line, actually, so that's fine. One to keep the Germans happy. Anyway, right. This is the way it used to be. Up until the late 80s, we had very few drugs. Now this, for the non-specialist, was quite good news. It was quite, in a way, simply reassuring, because actually there weren't that many options for treatment. We'll come back to the disadvantages of this, but this is what it was like when I first came into epilepsy clinics in the first years of the 90s. Then in the early 90s, after a sustained period of research by the pharmaceutical industry, and you have to say, the time and financial investment from this body of industry has been quite remarkable. We began to have drugs come on stream that really made quite a big difference in the clinics. Now, some of them have subsequently fallen by the wayside, but actually most of the clinics that we run today will be quite heavily dependent, particularly on the likes of lamotrigine or topiramate. As if that wasn't confusing enough, and this is where it began to really become quite bewildering for even general neurologists who were used to dealing with a handful of drugs and who then all of a sudden found themselves, just at the turn of the century, with oxcarbazepine and levetiracetam coming on stream. And then we had another 2 or 3 coming in quick succession, and then another 3 in the last 18 months. And now we've got possibly another 3 or 4 coming onto the market in the next 3 or 4 years. Now, that has many good aspects, but I think it has many bad aspects as well, and will leave us with a great deal of challenges over time. And the big question is going to be, is this going to make any sort of a difference? Well, one thing that might reassure us at first off, now I'm not suggesting that these drugs should never be used or will never be used in clinics, because of course in difficult epilepsies, in long-standing epilepsies, in patients who've done uniquely well on some of these drugs, they will remain highly efficient and useful treatments. But this is in some way to show that although we've got a big long list, we can shrink the list a wee bit. But if we move back the slide, we can see that's still a fair number of drugs that a doctor's got to learn how to use in a condition that used to be relatively simple to manage, and I put that in inverted commas, in the epilepsy clinics, has really become a bit more difficult. And this is a fairly bewildering list. This is a far longer list than you'll have to deal with, for instance, in a diabetic clinic or a Parkinson's clinic. This is where things really become quite complex. And this is one of the reasons why specialist epilepsy care, I think, is going to become even more important in the coming decade or so. So there I was, medical registrar, suddenly started doing epilepsy clinics in the late 1980s. And the few drugs that we had made life simple. We had few choices. Life was simpler then. There were only 4 TV channels and there were only 4 anti-epileptic drugs. The difficulty was the properties of the anti-epileptic drugs we had. They had a wide range of actions. They tended to cause quite a lot of sedation, and possibly making them even more difficult to handle was the fact that you didn't know, because of their pharmacological properties, the way that the body handled them, you didn't know what level was in the bloodstream because it didn't always correlate with what dose the patient was taking. And then, just to add an extra wee layer of complexity, each drug would affect the levels of the other drug. Now, that made great fun and games for pharmacologists and clinical pharmacologists, but it didn't make it much fun for general neurologists. It certainly didn't make it much fun for patients, where no one was quite sure what the drugs were going to be doing from week to week. And then in the early 90s, we began to have these other drugs come on. And of course, that led to a challenge that was quickly taken up by government. And government, as part of the review of drugs and services, as part of the guideline process, the NICE guidelines that you've heard so much about, suddenly thought there was real reason for taking an interest here. We had seen an increasing use of the new drugs. Way back when when vigabatrin and lamotrigine came on stream, they were used in a tiny minority of patients. By the mid-90s, we were seeing that 1 in 5 patients were using this, and I would imagine this figure has continued to creep up as the new drugs have become more numerous and, I think by inference, better and easier to use. You can see that figure looks quite breathtaking, £140 million in the average year, but really it's only just over 1% of the annual drug budget of the NHS. So although it's a big sum, comparatively it does do well. But government looks at this and thinks, really, we're used to using drugs like phenobarbital and phenytoin. These are drugs which are out of patent a long time ago. These are drugs which, to coin a phrase of one particularly eminent neurologist, cost more to put in the bottle than they did to make. And all of a sudden, the government was faced with a bill for £140 million for a wide variety of drugs. So they want to know, is this worth it? And as patients, you want to know, is this worth it, or are we just being taken for a wee ride here? What's good about the newer drugs? The sad fact is, if I took 100 patients who were diagnosed as having epilepsy in the early 80s, and I took 100 patients who were diagnosed as having epilepsy today, I would imagine that in time, the number of patients completely seizure-free will probably be roughly equivalent. I can't say that because of these new drugs, we've got 90% of patients seizure-free. It probably still sticks at around 2/3 of patients with epilepsy will be fully controlled on the medications we've got. I've got to agree with Mike on this point. It's sometimes, I think, facile to look at control of epilepsy as being purely a matter of seizure freedom or having seizures. The clinical psychologists like to look on it that way because that's the way they measure their scales. But actually, there are far more important things to measure. And as I alluded to earlier on, whether someone's been taken into hospital frequently or whether someone's going into bouts of status that need treatment with midazolam or rectal diazepam, that's just as important a thing. And that's not something that's routinely measured. What I know is that compared to my days as a medical registrar, we get fewer patients who seem to be hospitalised for status epilepticus. Now, I will struggle to find that replicated in the literature. But what I'm imagining is that that's partly to do with the ease of use of the drugs. So what I can say is the newer drugs are as good at preventing seizures as the older ones, but I can't say we'll have huge numbers of patients who are seizure-free, but that's not necessarily an indication that we're failing. It suggests we've still got a way to go, I don't deny that, but it's not a suggestion that we're worse off than we were in the 1980s. This looks at how well patients are doing, and this is one of the few data slides we've got. This is a big study called the SANAD study, and it compared one older drug, which is a carbamazepine, the black circles, with some of the newer drugs. Now, the statisticians will tell you about the differences between these medications when you get to the end of almost 6 years of treatment. But actually, when you look at it, they're all roughly in the same ballpark. We would all love it to be, in terms of success, up near the upper end of the range, and we'd love it to be even higher, of course, but when it comes down to it, we're roughly in the same ballpark. This is looking at patients who've been seizure-free, and the same measure applies. These drugs are slightly better, but only slightly better, and it takes a statistician to tell you that, but when you look at large cohorts of patients, it might not be apparent to you. This is the other way in which I think the drugs are much better nowadays. The side effect profile tends to be much better. Now, that might be just that we've got used to using these. We're much more cautious in our dosing, and we're much more skilled at using them and increasing and decreasing doses. But I think there's no doubt, and this is one of the things that was shown in the SANAD study, that actually patients tend to stay on the drug longer, and that's partly because they're better tolerated. And I think that also harks back to the idea of why we've got fewer patients, I think, who go into status epilepticus now, and that's because the patients tend to take their drugs more consistently because they don't have quite the same level of side effects. Useful side benefits. This is another thing. With this increasing range of treatments, we often have, we always talk about drug side effects, but actually a lot of drugs have side benefits too. And we look at some medications will aid in helping weight loss. We've got other medications that might help with mood stabilisation. We've got other medications that might help with sleep pattern. And this can sometimes be a useful thing in the clinic when you've got someone who's not doing well in anti-epileptic drug treatment. It can help your choice of the next one out of the batch by knowing which side benefits you'd like to recruit. Fewer interactions. Almost without exception, these newer drugs will not upset liver function, will not require such a stable liver function to give a stable blood level. We are much better at predicting the blood levels dependent on the dose the patient's taking. And this consistency and this degree of certainty is actually a big help in the clinic. And I have to say, it certainly helps us in that we don't have to run around checking drug levels on a frequent basis the way we used to back in the old days. Safer in special situations. Now, this is something we can say with certainty with the older group of newer drugs. We know that many of the older drugs have now been used in patients who've been pregnant for long enough that we can be fairly certain that these drugs are safe to use. I would stress that with the newer drugs, i.e. those who've been around for 15 years or less, it's much more difficult for us to be quite so certain because we don't have the amount of data. The one good thing I would say is that we now have much better processes for gathering the information about the effects of these drugs on pregnancy and on fetuses as they develop and on pregnant women. This is the big disadvantage, and this is what the government will continue to look at. This is why the government will continue to look at issues like generic substitution, because they'll say, oh, these drugs are 20 times more expensive than the older medications. Well, some of them may be 20 times, but 20 times not very much is actually still not very much. And despite what they'll keep telling us about ratios of cost, telling me that something's 20 times more expensive than something that costs 40 pence a day doesn't really win any arguments. Life is not perfect, but is better. This was a photo of a famous Glaswegian who uniquely in that other photo had a smile on his face. That was Alex Ferguson. So we'll move on from that. What's been better about epilepsy? Well, I've mentioned about the drugs and I've talked a lot about the drugs, and that has been an improvement. That's been something that's made doctors' lives easier in the clinic. More importantly, I think it's made patients with epilepsy's life better. But there are other aspects to epilepsy care. I think we've got better technology, which can help us make a clear diagnosis as to the cause of epilepsy. We're still nowhere near being absolutely firm about the exact diagnosis in every patient, but I think we're better off than we were in the days of skull x-rays and CT scans. We have more GPs, and Mike alluded to the government's drive to ensure that primary care takes more of an interest. I think we're still to see the payoff in this. I think many GPs unfortunately still have the idea that running an epilepsy clinic means you check someone's anti-epileptic drug levels. And I think there's more to it than that. And I've yet to see any firm grip by primary care, and I'm sorry if I'm offending any GPs here, there'll be a few militant ones outside waving their cord elbow patches at me, but they'll be outside telling me that's not true, we take great care of our epilepsy. I'm sure that's true, but it's patchy, and it's certainly not true all across the country. There are certainly more consultants. In terms of numbers of neurologists have gone from about 40 or 50 back in the late 60s up to well over 500 now. And I think the number in the last 20 years where we've seen consultant neurologists with a specific interest in epilepsy is on the increase. Is it high enough to manage to give good quality secondary and tertiary care for everyone with epilepsy? Is it high enough to make sure that anyone who's going to be exposed to these new drugs is going to have it done by someone with adequate skill and training? That's another question. But I think we're getting there, and we're certainly a lot closer than we were 15, 20 years ago. Epilepsy specialist nurses, and this is not just to curry favour with those in the room, but this has been a massive advance in the last 20 years. We've seen numbers climb gradually across the country, thankfully, and I think it would be a brave man that would try and set up an epilepsy service nowadays, trying to provide hands-on daily contact and increasing flexibility in the clinical service without also laying in time for some epilepsy nurses. Personally, I don't think with the current level of consultant numbers it can be done without nurses. That's not popular in these days of nursing shortages and getting nurses to go back onto the wards because, I'm sorry girls, we're a bit short-handed, but I think this is a fact, and I think it would be a much poorer service if we couldn't rely quite so much on the nurses. So what do we need? Well, of course, I'm a clinician. I'm going to say we need more clinicians, spending more time in clinics, seeing more patients, so that when you get newly diagnosed with epilepsy, you can be sure about the diagnosis and the classification and the treatment pathways. I think our clinical services have to be more responsive, which takes us back to the not only increased consultant numbers, but increased epilepsy nurses. Better technology, well, I'll hum and haw about that one. Of course, it'd be nice to have the next groovy scanner that goes bing and lights up the seizure responsive area in a wee bit of red, but that's not going to make a huge difference to an awful lot of people. More drugs. Again, this was alluded to in the previous one. Should we be racing headlong and grabbing firmly every drug that comes on the market, or should we be thinking about using the drugs that we've got more skillfully and more appropriately? And actually, this is where research comes in, because without research, we're not going to know exactly which processes underlie people's epilepsy, and if we don't know that, we're not going to be able to target drugs appropriately. This, I would think, if I was going to have one main aim for the next 25, 30 years about patients with epilepsy, it would be a good diagnosis when they're first seen at the clinic, and hopefully some sort of DNA genetic analysis that's going to tell you whether or not they're going to react badly to drugs, whether or not the epilepsy that they've got is going to respond well to individual drugs. Then you can end up with a short list that can shrink that list of that large list of treatments right down and help you target patients properly with the best drugs. And we can spend all the time we like in clinics seeing people and being nice to them. We can spend all the time seeing people when they've had a bad day and they've had lots of seizures. But actually in 25 years' time, the thing that's going to eat into that 30% who are continuing to have seizures is more research and more innovation. And I look forward to being part of that. Thanks very much.